Okay, hello everyone. Just checking in to see. It looks like we have about 15 participants here today. Just checking in if anyone can give me a reaction if they can see and hear me okay here as we get started.
Yes, we can see and hear you.
Okay, fabulous. Well, good afternoon, everyone, and welcome to today's Lunch Bite. I wanted to say thank you to Ally for supporting these lunch bites, and they do happen every third Wednesday of the month at 12 p.m. Central Time. So I am interested to know who is in this virtual space with us today. It's always wonderful to kind of ground and reflect on who you are and what experience that you have. And so if you want to, you're welcome to go ahead and drop your name, your pronouns, and maybe your primary occupational role in the webinar chat, the Q&A box. But just to introduce myself, my name is Tabitha Galindo. I use she, her pronouns. And today we will be talking about or examining evidence on the mind as not just an add-on to our sessions, but one of our primary physiological modulators. So in our previous lunch bite sessions, we addressed, can we even address mental health and can we bill for it? And the consensus was yes. But today we're shifting from feasibility a little bit more to what I'm going to argue is ethical necessity. So what we're looking at here is just a roadmap of the next 30 minutes we have to spend together. And the mind and body really both influence one another, but today we'll focus on ways that the mind influences the body, specifically three ways that the mind modulates movement outside of pain neuroscience. So we have many different ways that we could talk about mind and body, and with just our 30 minutes of time, we'll focus on the mind and movement. Um, and just like with the introductions, there may be times today during the webinar where you're cued to pause and chat, and welcome to write or drop something in that Zoom chat area. As well, I want to leave time for some questions, comments, and discussions at the end. Before we can really dive into the mind and body from a neuroscience perspective, I did want to at least visit a history of where we've come from, and specifically in Western medicine. So, Western medicine was built on the Cartesian split, this idea that the mind and the body are separate entities. This was rooted way back in 17th century philosophy, separating out that mind and body and really allowing medicine to treat the body as a distinct physical and biological entity. Often, this prioritized objective somatic parameters over subjective mental experiences in medicine. And in the Western medicine model, disease is often viewed as a distinct, specific identity with its own causes, like a pathogen, a mutation, a trauma, rather than a generalized imbalance of the whole system. Therefore, health was traditionally defined in negative terms, health being the absence of disease or an absence of deviation from normal functioning. And what we saw is that there was the specific model that emerged looking for problems, signs, symptoms, impairments, then categorized as classifications of diagnoses treated with clinical patterns, all falling under this disease model. Through this Western disease model, we then further developed specialties. And so, as Western medicine developed, specialties continued to tease out body systems further and further apart. Cardiology for the heart, orthopedics for MSK, dermatology for the skin, and so on. And then not so long ago, the physical therapy profession really emerged with a brand as the movement experts. So PTs improve the way you move. And while movement does cross multiple body systems, as we know, in the US, physical therapy has still largely followed that Western medicine model. And in our guide to physical therapy practice, we follow this workflow of examination, evaluation, diagnosis, intervention, so on and so forth. But what I want to call to your attention is that more and more literature is emerging, beginning to reject this Cartesian split of the mind and the body in modern medicine. And the question for you today is, are we as a profession following in suit? So if physical therapy improves the way you move and our mind influences why, how, when, and where we move, where in this model is it examination? Is it evaluation? Is it referral, diagnosis, prognosis, intervention, outcomes? Where are we really integrating the mind that's influencing how, when, why, and where we move? So with our next bit of time, we are going to cover specifically 3 ways that our mind, and more specifically our mental well-being, alters our movement patterns, again, outside of pain neuroscience. We'll start with the idea of goal-directed behavior. So recall that movement isn't simply muscle contraction. It's goal-directed behavior, our ability to plan, to initiate, and to execute actions. This requires very deliberate use of the mind, both between our unconscious and our conscious mind. So I'll show you this image here, and it really captures the unique integration of areas in our cerebral cortex. For example, our prefrontal cortex involved in planning and executive function with subcortical areas. And by subcortical, I mean those areas in the brain below the gray matter. Sometimes we think of these as our unconscious mind, things like the thalamus, the basal ganglia, and how they interact with one another. Something to note from this figure and these signaling loops is that it's simply that. It's a set or series of pathways that loop and signal one another, meaning that there is not just one pathway that the mind uses to direct movement. There's also not just one neurotransmitter or one imbalance of neurotransmitter that's implicated in movement or dysfunction of movement. Thus, central nervous system imbalances and mental health conditions can impact multiple parts of these loop that have to do with moving in relationship to our goals. More specifically, when a patient lacks motivation, lacks movement, lacks follow-through, we must consider, is this a neurochemical impairment? Here you see specifically 4 aspects or 4 subcategories of goal-directed behavior that are chemically impacted by one or more mental health conditions. So conditions like depression, PTSD, and anxiety have been shown in the literature to impact factors such as sense of motivation, ability to problem solve in real time, adaptability, meaning that ability to take a skill and transfer it or translate it or adjust in real time, and decision making, specifically related to values and reward systems, and whether that value or reward system has a positive affect driven or a negative affect driven behavior. So at this moment, I'll invite you to reflect. And again, if you'd like to pause and chat, how are these 4 traits, motivation, adaptability, problem solving, and decision making, related to movement-based activity, especially in the context of physical therapy or rehabilitation? So take a moment and drop in the chat, how are these traits related to what you might do in physical therapy practice? So it looks like someone called out motor learning. The elements of motor learning are simply, of course, implicated in our problem solving, our decision making, our adaptability, as well, thinking about adherence or compliance to a home exercise plan or a movement plan. Perhaps motivation to attend physical therapy sessions can be implicated in this. Self-efficacy. Yep, so someone talking about the capacity to feel that the efforts that they make will actually make a difference or improve their state of well-being. And lack of motivation, of course, can make physical activity very difficult to participate in. So thinking about whether patients are engaging in physical therapy, whether they feel the goals are salient, whether they feel that they're participating because of the reward or desire they have versus the punishment of non-compliance, all of these things can be influenced by their mental well-being and potentially by mental health conditions. So mental well-being impacts goal-directed behavior, which impacts a patient or client's ability to participate in physical therapy. Next, and someone alluded to this already through motor learning, but mental well-being impacts our learning and our memory. So attention, learning, and memory are very important for things like skill acquisition, error correction, and transference. Something I'll call to your attention is that physical therapy is fundamentally a teaching and learning profession. So we rely on a patient's ability to actively participate in skill acquisition and error correction. As a quick review, when someone is participating in procedural memory, that is encoding new physical skills or physical habits, it involves 3 stages. First, there's that cognitive stage of understanding a task and even exploring or finding the best method to complete that physical task. Then there is the associative stage, refining movements or skills required to complete the task, and that will involve that error correction, both taking external feedback, but also internal error correction and recognition. And then there's an autonomous stage where movement or skills become more automatic. They don't require as much attention. And again, what I want to point out to you today is that evidence indicates that many mental health conditions, including anxiety, substance use disorders, ADHD, schizophrenia, and chronic stress, impact our patients' neuroplasticity. Neuroplasticity does not belong to the world of neurophysical therapy. Neuroplasticity is essential to every part of physical therapy. And specific studies have been done in folks with trauma and folks with depression. And I want to at least call out those 2 specific conditions related to learning, memory, and cognitive ability. So trauma specifically has been related to atrophy, to shrinking dendritic connections and shrinking neuronal loss in the hippocampus, that seat of our memory and learning. And another thing to pay attention to is that multiple studies on depression, and most recently a systematic review and meta-analysis, noted that higher severity of depression and higher frequency of episodes of depression are strongly positively correlated with impairments in cognitive processing speed, as well as learning and both short and long-term memory. So for many folks, their brain is just structurally unable to prioritize long-term memory, and therefore the necessary steps for learning new movements, acquiring new physical skills, building those physical habits over their short-term survival signals in their mind. However, I do want to note, while mostly today we're talking about how the mind influences the body, many of these studies referenced also talk about how the body influences the mind. So exercise, aerobic movement actually specifically has a neuroprotective effect on neuroplasticity, especially related to cognitive demands. And so while the mind may influence the body and make it harder to build those new physical skills and habits, exercising and moving can actually improve cognitive capacity as well. So we looked at how mental well-being impacts a patient's ability to have goal-directed behavior, to be motivated to move. And now we've looked at how mental well-being impacts someone's ability to process, learn, and remember. So their ability to build those physical skills related to the profession. The last thing I want to talk about related to mind and body is how the mind literally influences tissue healing on a cellular level. So, mental well-being actually impacts our tissue's ability to repair. And we'll talk about this related to two specific body systems. The first one being the cutaneous system and wound healing. So, psychological stress, especially long-term stress as an independent factor, as well as other psychosocial factors, are actually associated consistently across the literature with impaired healing times. Stress-induced systemic inflammation because of the HPA, hypothalamic pituitary adrenal pathway, can persistently release cortisol into the body. Now, the acute response to cortisol being released in our body is actually to increase our pro-inflammatory cytokines, which then helps kick off or trigger that inflammatory response. But the thing to take away from this slide or this picture here is that with long-term psychological stress, we actually see a persistent activation of cortisol that can then shift the balance of pro and anti-inflammatory cytokines. And this shifted balance or responsiveness to our body's long-term stress can actually lead to less angiogenesis, slower tissue matrix formation, and ultimately increased time to heal. So our body's mental state in a long term influences our skin's ability to heal wounds. Even more interestingly to me was this model that came out in 2021. It was a hypothesis proposed looking at how the mind influences healing in the context of musculoskeletal conditions. And in these loops you see here, there's really three neurotransmitters implicated or involved. That is our serotonin, our norepinephrine, and our dopamine. So what we are looking at here is how prolonged cortisol exposure, again, because of that long-term stress, can cause resistance to glucocorticoid receptors, meaning those receptors are not as easily activated as they once were to cortisol. And because of that resistance, then we see this cycle, this self-perpetuating loop of what I'm going to call a neuroendocrine dysfunction. So stress-induced systemic inflammation can actively drive peripheral tissue pathology. This can accelerate swelling, it can increase persistent pain, and it can prolong musculoskeletal disease. But then from the other side, from the bottom up, peripheral tissue injury independently is sending inflammatory signals to the central nervous system. And this can trigger even more, of course, psychogenic distress. And so we see this persistent cycle where psychosocial factors, things like stress, mood, anxiety, and depression, are influencing our sleep, which influences our lifestyle, which influences our body's ability to tissue repair and heal, but also causing through their own cortisol pathway, amount of systemic inflammation. And when the central nervous system experiences systemic inflammation, it triggers more systemic resistance to inflammation in the peripheral nervous system. And so then the peripheral nervous system proliferates or prolongs the systemic inflammation, which then triggers more central nervous system inflammation, and so on and so forth. So again, I'm going to pause for a moment and allow you to kind of take in the greatness of what is this figure published in 2021. And I'll ask you another question here in the chat, which is when you look at this cycle, local inflammation, systemic inflammation, peripheral and central nervous system, tissue healing, lifestyle factors, where does the profession of physical therapy fit into this cycle? Where really can we intervene if this is a self-perpetuating loop of neuroendocrine dysfunction? So again, I'll pause here for a moment and let folks contribute to the chat and then see sort of what they have to share here. So it looks like someone said that lifestyle. Yes, so that lifestyle Physical activity, diet, smoking, alcohol, those are areas that the physical therapist or physical therapist assistant can intervene or can at least start a conversation, screen, or refer. As well, inflammation. So inflammation is everywhere, and the physical therapist or physical therapist assistant's ability to treat inflammation could be peripherally, could be managing that more local inflammation, but also could be central. So thinking about how patient education, strategies for relaxation, breath work, those things may be intervening more at the central nervous system level to help manage a peripheral condition, or we have modalities that can manage inflammation at a peripheral level to then help with the central inflammation. Yep, we had folks mention breath work, vagus nerve or polyvagal nerve work, absolutely. And then a mention of movement optimism and minimizing nocebo. Yep, so considering what are those top-down strategies and those bottom-up strategies and allowing the patient to choose. I think that one of the takeaways from our conversation or our chat here is we see folks talking about how physical therapy as a profession plays a role in pretty much every single bubble or every single portion mentioned here in this cycle. The mind is not separate from the body, but rather we can screen for and offer as a whole person interventions that address everything from the peripheral most musculoskeletal tissue up to the mind. And I love that Mike mentioned this, allow the patient to choose. What do you want to focus on for these interventions on a spectrum or on a continuum of mind and body, of central nervous system, peripheral nervous system, musculoskeletal issues. And this is holistic care as a whole. So I think what I want to sort of leave you with, or my call for action, if any, is if our mental well-being, our mind, impacts our ability or our patients' and clients' ability to plan steps and take actions to meet their goals. So that's salience, that's goal setting, that's adherence and compliance. If our mental well-being impacts our ability to learn, to recall, and to adapt movement, that is motor learning, that is acquisition of skills, that is transference of skills from the clinic out into the real world. And if our mind, our mental well-being impacts a patient's or client's ability to moderate inflammation and to literally heal their tissue, whether that's a wound in the skin, whether that's a ligament, whether that's a muscle, if our mind plays such a role in a patient or client's ability to do these things, then really, as the people who help folks improve the way they move, can we afford to ignore it? I would argue perhaps not. And so thank you for sort of joining me for this lunch bite session today. I hope that today was a small lesson in neuroscience, which I do love to teach, and a larger sort of call to action to the profession that we cannot think of the mind as an adjunct or a side therapy, but rather as a portion and a part of each step of the guide to physical therapist practice. So with that, here is a QR code for the references if you'd like to look at our references from today. And then we do have a little bit of time for questions and discussions. If you'd like to either use the chat or I can stop sharing my screen and we can discuss further from here. Thank you so much for your time today.
Dr. Galindo, there is one question in the Q&A. I don't know if you can see it. I can read it out loud. It's, what is the scope of physical therapy profession practice to help intervene in mental well-being? For example, I work as women's health PT in maternal health space. Sometimes I wonder how far I can extend providing treatment.
Absolutely. So I will do my best to answer here, and I happen to know we have some other experts in the room who can help answer. But what I would point out is that we have a professional scope We have a jurisdictional scope and we have a personal scope. So our professional scope, as defined by a House of Delegates updated sort of policy that passed a few years ago, says that physical therapy as a profession does play an active role, not just in screening, but also in evaluating and providing interventions for mental well-being. So as a profession, we do play a large role in mental health. But that being said, it's also important to pay attention to a jurisdictional scope, which is what state do you practice in? What is that State Practice Act and the laws around like mental health in that area? What does the legislature say? And then a personal scope. And our personal professional scope is to practice within the tools and the means that we are educated in. So, for example, my personal scope related to screening for, examining, or intervening around mental health conditions might be different than your personal scope based on the amount of training I have. I think the important thing to pay attention to is that yes, we can, and yes, we ought to. And once you are outside of your jurisdictional scope, outside of your personal scope, then I would suggest referring to a mental health provider. And as Lisa just mentioned in the chat, this first lunch bite in this series addressed scope of practice with the can we even address mental health conditions? And Lisa has kindly included a YouTube link here. So if you want to, you can go and watch a 30-minute webinar just on that. What can we do? It looks like we have a few other things in the chat here. So from Mike talking about how our predictive processing amplifies pain, injury, and symptoms. And our job is not to repress the tendency that predictive processing includes pain, injury, and symptoms, but to normalize it, give it action, give it agency, and to use evidence-based information, use motivational interviewing, use collaborative decision making to help folks choose from a list of how they want to go about with this mind-body connection related to skill development, rehab, and health span. Mike, I hope that captured your comment well, but thank you for contributing. I completely agree. And yes, there's lots of trainings from Joe Tata as well. He's got a whole website that looks at trainings if you're interested in expanding your own personal scope of practice. He's doing quite a bit of work related to not just interventions, but also what screening looks like for mental health conditions. Any other questions or comments? Okay, well, thank you so much, everyone, for attending this Lunch Bites webinar. I hope that we have a chance to see you at the next one. And again, this is a great chance to plug going back and watching some of the previous ones. They are on the YouTube channel and include Can We Even and Can We Bill for It? So if you want to watch those first two in the series, this is the next one. Thank you so much and have a wonderful day.